Hello everyone, welcome to another episode of Clinical Case Discussion. This is part 3 of parotid swelling. So today we are going to see the local examination and management part. Okay, right? So the first one is local examination. You know that the local examination of any swelling will include four important headings: inspection, palpation, percussion, auscultation. Well, all the four headings may not be applicable for every case. So here mainly we are going to deal with inspection and palpation. That is more specific for parotid swelling. So the first one is inspection. Again, in inspection, please understand whenever you are examining a parotid swelling, it is not just about the parotid swelling, but also about other adjacent anatomical structures which are present there. So one is the swelling per se. Second one is cervical lymph nodes, especially it is important in case of malignancy, and very important opposite side parotid gland. So we need to understand this is the algorithm to examine for a swelling, especially in the parotid region. Okay, right, next. So the first one is swelling per se. What are all the things that we should examine in parotid swelling? Just like for any other swelling, we need to mention which side is it is enlarged. Then another one is where is the site exactly, whether it is entire gland is enlarged or whether it is something specifically. Let's say I told you Wharton's tumor is more commonly seen in inferior aspect of the gland per se. So we need to tell where exactly the swelling is present within the gland. Then how many swellings are there? Well, whenever you are mentioning about size of the swelling in inspection, the word approximately should be used. And again, whenever you are mentioning the dimensions of the swelling, first vertical dimension followed by horizontal dimension. Like this, we need to mention, right? Then shape. What is the shape of the swelling? Then extent. To describe the extent, we need to take help of the adjacent anatomical landmarks. So for this extent, I'll write here. So one is superior, second one is inferior, then anterior, posterior. So where is the swelling extended till superiorly? So we can take help of the uh, anatomical process, that is nothing but zygoma. So dash centimeters from zygoma. Second one is inferiorly. If it is something like the whole gland is swollen or something like a little bit above, you can take help of angle of mandible. So dash centimeter from angle of mandible. Angle of mandible. Next is anteriorly, you can take help of angle of mouth. So anterior landmark is angle of mouth. Next is posteriorly, it depends on again the actual extent. You can take help of ear lobule if it is a small swelling, or you can take help of tip of the mastoid process. So posteriorly, you can take help of either ear lobule or tip of mastoid process. All right. Next, borders. Again, whenever you are mentioning anything in inspection, you better use the word appears to be. So borders appear to be well defined, regular or irregular, whatever it is. Then surface. Please understand, in inspection, surface has got only two conclusions. One, either it is even or uneven. You cannot mention whether it is smooth, nodular, etc. etc. They are all palpatory findings. So in inspection, surface has only two things: either it is even or uneven. Then skin or the swelling. What are all the things we should examine for skin or the swelling? One, there is any whether there is any scar over this region to rule out recurrence. Then engorged veins. Visible pulsations are generally rare, and redness. Redness indicates usually it may be an acute inflammatory swelling. Engorged veins will usually suggest it could be a malignancy. Then raising of ear lobule, very important. The two important specific findings in inspection for a parotid swelling is if it is a large swelling, there will be raising of ear lobule. So how will you examine for raising of ear lobule means either you should stand either in front of the patient or behind the patient and you should compare both sides. Then you can easily appreciate the raising of the ear lobule. Then obliteration of retromandibular groove. So this is the mandible you are having. Behind the mandible, this area is called retromandibular groove. So whenever there is a little bit significant size swelling, it will obliterate this retromandibular groove. So these are the two important specific findings in inspection to say it is a parotid swelling. So one is raising of ear lobule, second one is obliteration of retromandibular groove. So the examiner can trickily ask you which parotid swelling may not cause the raising of ear lobule. So it may be something like a very small swelling. Then the ear lobule need not be raised. Okay, right. Next. So apart from the swelling per se, we need to mention whether there are any visible enlarged cervical lymph nodes. Usually they can be seen in case of malignancy. Then opposite parotid region. It is very important to understand why you should examine for opposite parotid region, because there are certain conditions which will affect the bilateral parotid gland. What are they? So first one is, you can remember easily, infection, tumors and others. So the important infections are virus, that is nothing but mumps, Silidinosis, HIV associated silidinitis, granulomata silidinitis. These are the common infections. Coming to tumors, one important tumor which can occur bilaterally is Warthin's. Then very rarely pleo, and rarely again malignancy, other malignancies. Okay, please understand Warthin's and pleo are benign tumors of parotid gland. Then other condition which can cause bilateral parotid enlargement is sarcoidosis. Okay, right. Next. Coming to palpation, after inspection, so you know the universal first things to be examined in palpation. For parotid swelling, usually the order which can be followed is one, parotid swelling per se. Then I told you it's not just about the swelling per se, but also the other anatomical structures in and around. So you know that the one important nerve you have here is facial nerve. Then lymph nodes, followed by oral cavity and others. And obviously at the end, you should always make a comment about opposite parotid swelling also, right? So first we will see parotid swelling. So you know that the two important findings that should be examined first in palpation anywhere is localize of temperature, local tenderness. Then you will just mention, you will take a measuring tape and whatever you have told the word with approximately, now you will measure everything and you will describe the exact parameters. So where is it? How much is the size? What is the shape? What is the extent? Again, for the extent, just like we have discussed in inspection, we will take the same anatomical landmarks and you will mention the extent of the swelling with respect to those anatomical landmarks, right? Next, borders. We will palpate the borders with your hand and then you will mention whether they are well defined or not and whether they are regular or not. Then coming to surface, what are the different surfaces you can encounter in a parotid swelling? So one is nodular. So where will you see nodular? Usually pleomorphic adenoma. Then irregular. You know that it is usually common in case of malignancy. But as compared to pleomorphic adenoma, in contrast to that, Warthin's tumor is something like a cystic component, and the swelling surface will be smooth. So when you palpate it, it will be something like a smooth swelling. Then please remember, not only in parotid swelling, any swelling per se, what are the three most important specific findings you will examine for in palpation is, you can remember with the help of a mnemonic, CPM. So C for consistency, P for plane of the swelling, M for mobility of the swelling. Okay, so we need to understand how they are important in parotid swelling. And last but not the least, you should understand parotid duct. So you must always examine for the parotid duct by bidigital palpation. I told you parotid duct. The topographical landmark of parotid duct is middle one third of an imaginary line drawn between midpoint of ala of the nose and angle of the mouth anteriorly and tragus of the ear posteriorly. So the middle one third of this line will represent parotid duct. Two important things you need to understand is middle one third of the imaginary line. That's where you have to check. And how will you check means you will ask the patient to clench the teeth. So against tout masseter, you will always check against tout masseter muscle. Right, now we will see consistency, plane and mobility, how they are important in parotid swelling. Okay, the first one is consistency. So you know that the three important types of consistency is, one is soft, firm and hard. Usually soft, I told you Warthin's tumor is a cystic and the surface is also a little bit smooth, so you can have Warthin's which has soft inconsistency. Then form, you can take example of pleomorphic adenoma. Actually, pleomorphic adenoma has got a variable consistency because each component is different in case of pleomorphic adenoma. And you know that heart is usually seen in malignancy. Okay, right. Next, coming to plane of the swelling. So next one is plane of the swelling. To understand plane of the swelling, first we will see whether it is infiltrating or involving the skin or not. You will pinch the skin or the swelling, and if you are able to pinch it separately, you know that skin is not involved. Okay, right. The second one is beneath the skin in this anatomical region, the next layer that is present is nothing but your parotid sheath. Okay, so parotid sheath has got two layers. We will see that. Okay, I'll just show you the picture. So these are the two important layers of parotid fascia, which is also called parotid sheath. Okay, so one is superficial lamina, second one is deep lamina. Okay, so the next one is our aim is to know whether the swelling is coming from superficial to this sheath or deep to the parotid fascia. How will you do that? Initially, in the resting state, you will examine the mobility of the swelling. Then you will ask the patient to open the mouth. This will stretch this parotid fascia, and you know the math. Whenever a swelling is becoming more prominent when a fascia is stretched, it means that swelling is present superficial to that fascia. But in contrast to that, if the swelling is becoming less prominent when it is stretched, it means that swelling is present deep to the fascia. Okay. So how do you stretch the parotid fascia means ask the patient to open the mouth. That's one important point you should understand, right? Next. And now you want to know if it is something like a large swelling which is hard and you are suspecting malignancy, you want to know whether mesoter is involved or not. So to understand that mesoter involvement, whether the tumor is fixed to mesoter or not, initially, just like previously, you will examine for the mobility of the swelling in resting state. Then you will ask the patient to clench the teeth so that clenching of the teeth will make the mesoter muscle contracted. Now again with the taut mesoter, you will check for the mobility of the swelling. Now, if there is any sort of restricted mobility with mesoter in contraction, it means that the swelling or the tumor is fixed to the mesoter muscle. Instead of that, if there is no change in the mobility of the swelling, if it is same like before, it means that swelling is not fixed to the mesoter. Okay, right. Next. So this is the parotid sheath that we were talking about. So there are two important lamina. One is superficial lamina, another one is deep lamina. Now we are going to see how this anatomical point is important in clinical examination. So nothing but mobility. You know, usually if it is something like a parotid swelling, it will be mobile in all other directions except superior direction. So there is restricted mobility in superior direction because you can see here there is limitation by the parotid sheath which is attached to the zygomatic arch. So this parotid sheath is attached to the inferior border of the zygomatic arch. That is why whenever you are trying to mobilize, move this parotid swelling, it cannot move beyond the zygomatic arch. So this particular sign is called curtain sign. Okay. So what is curtain sign in mobility of the parotid swelling? It is nothing but restricted mobility of parotid swelling in which direction? In superior direction. Why is there restriction? Because of the anatomical extent of the parotid sheath which is attached to the inferior border of superior direction, superior aspect at the inferior border of the zygomatic arch. So at this juncture, the examiner can ask you one important question: what is the anatomical configuration of this deep cervical fascia? You know that deep cervical fascia has got three important layers: investing layer, pretracheal layer, prevertebral layer. So this investing layer of deep cervical fascia, it will start at somewhere at the superior nuchal line. It will extend anteriorly at the level of this mastoid process. It will divide into two lamina. This superficial lamina, so you can see here, this is the investing layer I am talking about. So it will split into two layers. The superficial layer will cover the superficial aspect of the parotid gland and it will attach to the inferior border of the zygomatic arch. Whereas the deep lamina will go medial direction and it is attached to the styloid process and here to the mandible. That's where you are having one important ligament which is called stylomandibular ligament. So just break down the words. Styloid process, mandible. So stylomandibular ligament and it is also attached to the tympanic plate. Okay. So this is the anatomical configuration of investing layer of deep cervical fascia, and the rest of the part will be continued on to the anterior aspect of the neck. Okay, right. So this is the anatomical point of parotid sheath, which is clinically correlated to something called curtain sign. Very important, right? Next. So after the swelling per se, now we are moving to the next second subcomponent in palpation. That is nothing but facial nerve examination. So I told you there are five important terminal branches of facial nerve and the respective muscles supplied by them. So we are taking help of the anatomical points to examine facial nerve here. So I told you temporal branch is related to your occipitofrontalis muscle and also orbicularis oculi. Sorry, zygomatic branch will supply the orbicularis oculi. So you know here you will ask the patient clinically to raise the eyebrows. So this will make frontal belly of occipitofrontalis, and you can see whenever someone is raising the eyebrows, you can see small wrinkles here. And if there is any absence of such wrinkles here, it means that frontal belly of occipitofrontalis is paralyzed. Okay, right. Next, you'll ask the patient to close the eyes. So here, which muscle is getting contracted? Orbicularis oculi. If the patient is not able to do close the eyes permanently, I mean completely, and whenever normally in you and me, whenever we are closing the eyes, the eyeball will get uprolled like in medial direction and superior direction, superomedial direction. That is called Bell's phenomenon. But you cannot observe Bell's phenomenon in you and me in normal people because of the closing of the eye. In facial nerve paralysis, this orbicularis oculi is not functioning properly. That is why you can observe Bell's phenomenon clearly. What is Bell's phenomenon? It is nothing but rolling of eyeball superomedially. Rolling of eyeball superomedially. That is called Bell's phenomenon. Now, you'll ask the patient to look at his glabella. So, nothing but frowning. So, the muscle responsible for frowning is corrugator superciliary. Okay, right. Next, you need to observe for the nasolabial fold. I told you in the previous class, levator labii superiorris aliquois nasi is the muscle which is responsible for the medial nasolabial fold. Whenever there is facial nerve paralysis, this nasolabial fold is lost, right? Then you will ask the patient to blow the cheeks. So the muscle related to this action is buccinator. So buccal branch of facial nerve will supply to that muscle. Now you will ask the patient to whistle. So what is the muscle related to whistling is orbicularis oris around the mouth. Okay, and the nerves related are buccal branch and marginal mandibular branch. And you will ask the patient to show the teeth so that you will observe for the angles. If at all there is any deviation of angle of the mouth, normally the angle of mouth is kept in position by two important muscles. One is levator anguli oris, second one is depressor anguli oris. Whenever there is facial nerve paralysis, this cannot be maintained anatomically. That is why there will be deviation of angle of mouth. And lastly, please understand platysma is also supplied by facial nerve. So, how will you test for platysma means you will ask the patient to either stretch the neck or you will ask the patient to avert the lower lip like this so that this will make platysma contracted. If it is something like a very severe paralysis, you can easily observe platysma sign also, right? Next. This is about facial nerve examination. So you can easily remember, ask the patient to do, and for that particular action, which muscle is responsible and what nerve is applying to that particular muscle. Okay, right. Next. Now coming to cervical lymph nodes, I told you in parotid malignancies, usually level 2 and level 3 are mainly involved. So upper and middle jugular lymph nodes. Why is it important to check for cervical lymph nodes? Also, another important thing regarding lymph node, the word lymph node is that the examiner will ask you this common question. I would say it is enlarged preauricular lymph node. You are telling it is a parotid gland. How will you justify your answer? So to understand this, you need to tabulate the differences between preauricular lymph node enlargement and a parotid swelling. So you can see here, whenever if you think it could be a enlarged preauricular lymph node, there will be positive history. Like these particular draining areas of the lymph node, there will be related history like dandruff or any infection or any trauma, history of tobacco or betel nut chewing in an oral cavity, because it will cause cancer, oral cavity cancer, which will metastasize to this particular lymph node. This is will be the history. Whereas in case of parotid, you know the classical, there is nothing like a specific history. Then In inspection, there are no much findings in enlarged preauricular lymph node, but in palpation, I told you it can be usually if it is a reactive lymph node. That means if the enlarged lymph node is in response to an infection, that is called reactive lymphadenopathy, it will be firm. Whereas if it is something like a metastatic lymph node, it will be hard. Then I told you in plane of the swelling, usually majority of the lymphatics or lymph nodes are present superficial to the parotid sheath. So when we are checking for the plane of the swelling, this enlarged preauricular lymph node will be superficial to the parotid sheath. Whereas you can see here, parotid is present deep to the parotid sheath. Then mobility, it will be mobile in all direction except in metastatic lymph node. If it is something like a reactive lymph node or non-malignant lymph node, it will be mobile in all direction. But in case of parotid swelling, there will be positive curtain sign. Okay. Apart from that, you can see the specific findings in inspection for parotid swelling. I told you two important findings. One is raising up of ear lobule. Second one is retromandibular groove. And the other important point you should understand is in inspection, and this will be one of the most important questions the examiner will ask you. The swelling is present in the parotid region. Obviously, preauricular lymph node is also present in parotid region only. We will see. I told you in previous class what is parotid region and what is its clinical significance. Any swelling seen or present in parotid region is considered to be parotid gland swelling unless proven otherwise, right? So again in palpation, it can be variable consistency in pleomorphic adenoma or hard in case of malignancy. Okay, right. So these are the important findings and differences between enlarged preauricular lymph node and parotid swelling, right? Next one. So after all these things, you need to go for oral cavity examination. What are all the things we should see in oral cavity examination? First one is adequacy of opening of mouth. Why should you check for this? In a case of advanced parotid malignancy, there can be infiltration of temporomandibular joint. In such conditions, patient will not be able to open the mouth freely. There will be restriction. So that's why you have to check. Then apart from that, oral hygiene. You should check whether there are any tobacco staining or any other ulcers or any improper hygiene and all you should check for. Then uvula. You should always check for uvula whether it is in midline or whether there is any displacement. Why is it important to check for the position of uvula? I told you whenever deep lobe of the parotid gland is involved, that will push the ipsilateral tonsils and also the uvula to opposite side. That is why you should always check for the midline position of uvula. The same applies for the tonsillar fossa or pillars. So this is mainly important to check whether deep lobe has been involved or not. Right? Next, parotid duct opening. I told you this Tenson's duct will open at opposite to crown of upper second molar tooth. So as you can see here in the picture, this is the parotid duct opening. What are the important things you should check? In case of acute parotid swelling, you should see whether there is any stone sitting at the parotid duct opening or whether there is any discharge from that particular opening, and also whether there is any surrounding erythema around that duct opening. These are the important findings you should always check. Then for the deep lobe of the parotid gland, you should always check it for bidigital or bimanual palpation. That's how you should check. Along with that, in oral cavity, I told you submandibular duct opening is present in the floor of mouth or oral cavity. Floor of oral cavity on either side of the frenulum linguae. These are all the important findings you should examine for in case of oral cavity examination. Then must and should you should always check for other major salivary glands. At the end of palpation, before you proceed to the facial nerve examination or just at the end of palpation, you need to make one comment. Opposite side parotid region is normal to rule out bilaterality. Okay. Now after the examination, like after the local examination, I think I have missed one empty slide here. So after local examination is over, you should always mention about systemic examination. Systemic examination. So I told you in the video of introduction to case sheet writing. So you need to mention CVS, respiratory system, then parabdomen, then central nervous system. So you will mention if there is, if anything is in specific, you have a finding there, you will mention. Otherwise, you can simply tell systemic examination is unremarkable. If there is any particular abnormality, you can mention. Okay, right. So bilateral air entry is present and clear or normal vesicular breath sounds present bilaterally. Then per abdomen, soft, non-tender. Then CNS, no focal neurological deficit. Okay. So after systemic examination, you will proceed for the provisional diagnosis. So I told you in the video of introduction to case sheet writing, for each particular case, you have specific headings in the provisional diagnosis. So for a parotid swelling, you have got three important headings. One is anatomical diagnosis, pathological diagnosis, whether it is associated with any complications or not. So you will mention whether it is right side or left side. Then right side parotid swelling, probably a benign tumor. If it is benign, you will mention mixed parotid tumor is nothing but it is just another name for pleomorphic adenoma. Pleomorphic adenoma is something like a pathological term, and mixed parotid term is a something like a clinical term. Okay, so better you use the word mixed parotid tumor rather than pleomorphic adenoma. And whether there are any associated complications like whether there is any lymphadenopathy or facial nerve involvement is there or not, you should tell. Okay, so these are the important components of provisional diagnosis in a parotid swelling.